all of you a happy holiday, Merry Christmas, Happy Hanukkah, and a happy 2026. May it be successful, healthy, productive, and fulfilling. Today's session is the last one of the year. The next one we'll be doing is on the 10th of January because I'll be out of the country, leaving on Monday. I'll be back after the new year and we'll resume our live feeds every week starting on the 10th of January. So please make a note of that. I'll come back and remind you later on because of course we're early in the feed, so I'm sure we haven't got a lot of your attentions yet. Today's sessions are going to be focused, as we've been promoting, on three broad categories: endometriosis and infertility, with special emphasis on what we can do to enhance opportunity to conceive through IVF, and when is IVF needed for endometriosis, when is it not needed, and we'll talk about that. The second one is going to be on recurrent pregnancy loss or recurrent miscarriages. I'll be taking your questions on that topic. It's been a very popular subject matter, so please feel free to put your questions together on that. And the third one is going to be on the unexplained IVF failures, which can be due to immunologic causes. And I'm going to take questions on immunologic causes of unexplained or repeated IVF failure. So with that, Josh and I are ready to go. I think we have some questions. This is responsible when it's affecting you personally or is in your family for about 80% of the causes of immunologic implantation dysfunction. In 20% of cases, the cause is not linked to autoimmunity. It's linked rather to something we call alloimmunity. And that happens when there is a genetic similarity between the embryo and the woman's uterus. Let me explain. There are certain genes that we all harbor. Each human being's got two sets of genes. One comes from our mothers, one from our fathers. And there's a gene called DQ alpha, HLA, which is present on chromosome pair number 6 of 23. And when the DQ alpha of the male partner matches one of the DQ alphas that the woman harbors in her uterus, it's not the egg and the sperm, it's the embryo and the uterus, then the embryo is genetically too similar to the woman's body, and the body regards it as being an invading organism and sets up an immune reaction that rejects the embryo. Interestingly, in both the autoimmune and this second cause, known as the alloimmune cause, there's always underlying it activation of natural killer cells and to some extent T cells, but mainly natural killer cells. These are large immune cells that reach the uterus from the woman's bone marrow every month. They multiply in the uterus, and around the time that the embryo is supposed to attach, they start releasing growth factors called cytokines that regulate the attachment of the embryo to the uterus. In the autoimmune variety, it's caused by this reaction of the body reacting to its own tissues. In the alloimmune variety, the natural killer cells start to overproduce one of these cytokines known as type 1 cytokines that attack the roots of the embryo and destroy it. In both cases, the type 1 cytokines, Th1 cytokines, are at fault. In the autoimmune variety, the treatment is usually to treat the natural killer cell activation with either IVIG, which is something we used to use, it's a blood product, we don't use it anymore, or intralipid, whereas in the alloimmune variety it's the same, but the treatment regimes differ and the alloimmune is far more difficult to correct. It's extremely important to differentiate between the two, and unfortunately, your regular reference laboratory can test for activation, which means overproduction of Th1 cytokines by the natural killer cells. The blood's got to go to one of 3 or 4 labs in the United States that are capable of doing an adequate test for these natural killer cells to see if they're overproducing these type 1 cytokines known as activated natural killer cells in those circumstances. And when they are, then we direct the treatment to the cause. Associated with this, we often have other subsidiary immunologic problems affecting elements like antiphospholipid antibodies, the types of lymphocytes or immune cells present, we call that an immunophenotype, and of course the absence or presence of thyroid antibodies. And in the case of the alloimmune variety, we test those as well, but our main emphasis is upon trying to regulate the cytokines to make them in balance so we don't get destruction of the embryo and its eviction. If the embryo is destroyed by these activated natural killer cells before it registers a pregnancy, either by a positive pregnancy test or ultrasound evidence of a pregnancy, if it does that, it presents as either what we call a chemical pregnancy or a miscarriage, early miscarriage. Usually with the autoimmune variety, women present to us with unexplained inability to conceive or unexplained IVF failures. Whereas with the alloimmune variety, they usually present with repeated miscarriages. Not always, but they usually do. As I say, both are treated using something aimed at regulating the cytokine balance, intralipid and IVIG, and sometimes Lovenox, which is a heparin-like substance, sometimes, but very rarely, baby aspirin, and so forth. But we can answer these in specific questions as they come aboard.
Okay, we have a bunch of questions right now. We are going to try to answer as many as we can. We are live on 3 platforms at once, so bear with us. We're going to start on Instagram real quick here. Looks like we have a good amount of questions here. So we're going to start with Mary. She says, "Hi doctor, could we talk about the first miscarriage? I am now 9 months trying to conceive naturally without having a pregnancy." I think she'd like to know the cause or maybe some reasons.
She had a miscarriage.
It sounds like she had 1 miscarriage and now she's been trying for the last 9 months with no pregnancy.
Okay, well, first of all, miscarriages occur across the board. The incidence is 10 to 12% of pregnancies. Miscarriages where you lose the pregnancy before it's viable. You can see it by ultrasound, the woman bleeds, and then the pregnancy is lost. The causes of miscarriages are many, but the vast majority of such miscarriages, which we refer to as sporadic miscarriages, are due to the embryo being abnormal, meaning usually there's a chromosomal irregularity in the embryo. All human cells are 46 chromosomes. The embryo also does. And if that embryo has more than or less than 46, we refer to it as being aneuploid. That's the commonest cause of miscarriage. It can also occur when the problem is not in the chromosomes, but in the genes. Genetic causes can also cause sporadic miscarriages. And you having had 1 miscarriage isn't a reason to focus heavily on the miscarriage. Probably more important in your case now is to focus on why you're not getting pregnant again easily. And if you don't get pregnant for more than a year after trying, in spite of having had 1 miscarriage, then we need to look at the causes of inability to conceive, and it falls into the realm of infertility. When women have repeated miscarriages, 1 after the other, 2 or more in a row, we refer to this as recurrent miscarriage or recurrent pregnancy loss. Then, as I said earlier, the commonest reason is that there could be a failure of the embryo's ability to attach to the uterine wall, rather than it being due to the embryo being abnormal. And if it's due to a failure of the embryo to attach, it usually means there's something wrong with the lining of the uterus, either because it's been inflamed. That often happens if you had a miscarriage, and that miscarriage then becomes infected. Some of the products of the miscarriage don't get expelled, and inflammation damages the inside of the uterus. In those cases, the lining can be damaged and not be able to grow thick enough to allow the roots of the embryo to attach properly. Or there can be scar tissue in the uterus. Sometimes there are polyps, irregularities in the cavity of the uterus. And in some women, very common in African American women, there are fibroid tumors, benign little whorled fibrous tumors in the wall of the uterus that protrude into the cavity and irritate the lining. These are anatomical causes, and in other cases the lining is just too thin. There's not enough room for the roots of the embryo to expand into. As I said, these are anatomical causes. And as I mentioned earlier on, there can be immunologic reasons why the embryo won't attach as well. And so if you have had one miscarriage and then there's been a hiatus of 9 months, it's possible that that miscarriage, after you lost part of the pregnancy, the products that remained inside became inflamed and damaged the uterus. But most commonly, that miscarriage was due to an abnormality of the embryo. And what we've got to focus on now is whether you've been left with some or other residual problem where there's a failure of the embryo to attach to the uterus, causing you to have infertility. Again, give it a few more months. If you're not pregnant, then get back to us. And if you want to know more about miscarriages, I urge you to comment the word "share" in the most recent video report, short video that I did. We will get back to you, and I will send you free of charge 2 downloadable ebooks that will arrive with you. The books have been written by me and my partner, Dr. Drew Tortoriello. He is the medical director of my program in New York. He and I wrote the one thick book together. It's very current. It's not out yet, but it's available, and we'll send it to you as a free downloadable ebook. And the other book I'll send you is a thin book on the immunology of repeated miscarriages and unexplained IVF failure. It's a much shorter book, and it's worth reading because you're not going to get that information elsewhere that easily. So I urge you to basically comment the word "share," and we will send you these books by return. We'll get right back to you.
Sounds good. Thank you guys all for commenting. There's a lot of comments here coming through. We're going to try to get to as many as we can today. We are live on 3 platforms. I see people subscribing, liking. Just thank you all. If you're on YouTube, comment the word "share" on Dr. Sher's Instagram, and someone will reach out to you shortly here. Anyone commenting the word "share" on the live stream, we cannot reach out to you directly through here, so please go comment on the most recent video, and we'll reach out to you. All right, let's jump over onto TikTok.
And again, reaching out means you will get free downloadable ebooks from us by return once you put the information down.
Yes, sir. All right, so I'm going to go over here. Let me see. I'm going to answer this one. So someone says, I took a test December 12th. It was negative. I still haven't started my cycle. Can anyone help me? She says my cycle was due now on November 11th. Don't know if that's relevant to...
I don't know if she did a test straight when a period was due. It might have been too early for the pregnancy test to be positive.
Yeah.
If she was hoping to be pregnant, you may have to give it a week and repeat it.
That was Misty. Let me go down a little bit. Let's go back to Instagram. We have a bunch of people waiting on Instagram here. Alright, let's ask. Does the time from egg collection to insemination with ICSI play a role in success, especially in older women? I have been pregnant naturally, but have done 19 rounds of egg collections and no luck.
Wow. I'm assuming you've had IVF egg collections, and you've probably also had embryo transfers and not conceived. This is clearly a problem. If you've had so many egg collections and you've had embryos put in your uterus and you've not conceived, there could be problems there, and you need to evaluate the possible causes. And I've mentioned earlier on, the commonest reason embryos don't attach is because they're not normal, and when they're not normal, it's because they're chromosomally abnormal or aneuploid in most cases, not all. Some are due to metabolic causes, other due to genetic causes. That's the commonest cause that the embryo doesn't attach. And here's the important message. It usually stems from the egg and not the sperm. Of course, the sperm, if it's abnormal, can play a role in generating an abnormal embryo which won't attach. But if it's usually the egg in more than 80% of cases, unless the man has got a very significant sperm problem based upon sperm testing and other things that can be done. But if you've had repeated IVF attempts and you haven't had eggs that have made embryos, in other words, the egg collections have failed, either you haven't got all the eggs out, or you've ended up with eggs that have not propagated healthy, viable embryos for use, it's very important to consider other possible causes. And if that happens, it's very often due to the protocol used for ovarian stimulation. Let me restate this. You can't use a one-size-fits-all protocol. You've got to use an individualized approach to ovarian stimulation, especially in women that are older, at or beyond the age of 40, and women that have got few eggs left. We refer to that as having diminished ovarian reserve, something we can pick up quite easily if the woman has got an AMH, anti-Mullerian hormone, AMH blood level that is low, under 1.5 in American units or under 10 in Canadian or European or Australian units. So if your AMH is low, as an indication that there are fewer eggs, you've used most of your eggs up and you're running out of them, it'll interfere with the hormonal environment in the ovary. And now there's an essential necessity to tailor-make the protocol to address that problem, because if you don't, you end up repeatedly getting abnormal eggs and therefore abnormal embryos, and that will either present as failure to conceive or miscarriages. So very important is the protocol to be used for ovarian stimulation. In your case, with so many failures, I think I can help you. And I urge you to consider the possibility of maybe emailing my assistant Patty at concierge, CONCIERGE, at sherivf.com, concierge at sher, SHERIVF.com. And she'll set you up with an online consultation with me to discuss your case. Your type of problem is exactly the type of problem I like to deal with, so feel free to call her and she'll set it up for you. Also, comment the word share in the most recent of my videos, and we'll send you copies of my books that I've referred to earlier. Free books, which will come to you. We'll get your information and send it to you, and we'll go from there.
All right, I want to answer Stephanie's here on TikTok. We will get to as many questions as you can. Bear with us. If you're commenting the word share on the live stream, please go comment that same word on our most recent video, and we will reach out to you with the free ebooks. All right, I'm going to answer Stephanie's here real quick. It says, best transfer protocol for recurrent pregnancy loss and endometriosis stages 3 through 4.
The embryo transfer process that you use should be the same for everybody. There are variations on the theme. It doesn't matter what the cause of the problem is. The idea is to get an embryo into the uterus at the right time, very atraumatically, gently, and we pass a thin catheter through the opening of the cervix into the uterus, with a woman completely relaxed, lying on her back in what we call the lithotomy position. We put a speculum into the vaginal area, and so we can visualize the cervix. Then we make sure there's no abnormalities of the cervix. An abdominal ultrasound allows us to visualize the uterus and the inner lining of the uterus, and that thin catheter is then passed through a little metal cannula, and that's introduced gently through the cervical canal into the uterus. If you know what you're doing, you can track it quite easily. The more traumatic it is, if you've got to use things to dilate the cervix, or if you've got to use probes to get into the uterus, you're jeopardizing the chance of success. So it's very important that the person who does the transfer be experienced. And so then you pass the catheter gently into the uterus, avoiding going too far. You want to place the tip of the catheter just about a centimeter below the top of the uterus. The embryo is loaded into that thin catheter and discharged gently into the uterus. You then withdraw the catheter and withdraw the cannula and remove the speculum, and the woman lies relaxed without any stress or pressure, lies still for about 15 to 20 minutes, and then we move the woman out of the procedure room into the recovery area, where she remains relaxed, lying down for about half an hour before she goes home. Very often we'll use some relaxants, some Valium or something, some tranquilizers before the egg retrieval procedure to calm the woman. In some cases, if a woman is extremely agitated, we may feel that she's not going to lie still, or if we feel that there's an anatomical reason to make it more difficult, we'll have the anesthesiologist come in and put the woman under conscious sedation, using drugs like propofol to keep her completely out so she doesn't interfere as we do the transfer. Another important point is that in order to visualize the uterus by ultrasound, when you do the transvaginal introduction of the catheter, we need the woman to have a full bladder. So we'll usually have the woman drink a lot of water before the transfer, half an hour to an hour before, and we'll check before we do the transfer that the bladder is distended. And there are very good reasons to have a full bladder. The first reason is that there's a reflex shutting down of uterine contractions if the bladder is full. So by basically distending the bladder, we keep the uterus quiet so it doesn't contract and expel the embryo once we put it in. The other reason is we can see the uterus better. The bladder will push the uterus into a flat position. Otherwise, it's often tilted backwards or forwards. But by filling the bladder, we bring the uterus into what we call an axial position, and then we transfer the embryo with the uterus in that position. We will usually, if it's very distended, empty the bladder after the transfer, or otherwise, when the woman gets back to the recovery area, she can empty the bladder herself.
Alright, let me go back up here. We've got some people who've been waiting on Instagram. Let me go over to theirs.
Okay, one last thing, sorry, Josh.
Go ahead.
Embryo transfer is a very important part of IVF. The doctor doing it's got to be experienced and know what they're doing. I have written quite widely on embryo transfer in my book. One of the books that we will send you. All you have to do is comment the word Sher and comment it on the most recent video that I've done, and we will send you free downloadable ebooks. There'll be a chapter on embryo transfer in the one thick book, which is over 300 pages long. Again, it comes as a downloadable ebook, and you can read that very carefully. And if you need more information, you can contact us directly, or you can reach out to me. I'll be happy to talk to you online.
All right, thank you all for commenting. We're going to try to get to everybody as soon as we can. There's a lot of questions between the three platforms here, so we're going back and forth between each one. I want to answer this one right here real quick. It says, miscarried at 5 weeks with a PGTA tested euploid. Body did not absorb the progesterone and had allergic skin reaction to injections. Now bled and HCG is rising. What could be the cause?
If you've had a bleed, and this happened after an embryo transfer, but the pregnancy HCG hormone is still going up, you've got to be careful. You've got to make sure that they're not retained products of conception that are still producing HCG. So you need to do an ultrasound examination to make sure the uterus is empty. If there are products of conception in the uterus and the HCG is going up, you need to empty the uterus by doing a DNC. You can do that to clean out the uterus and then follow the HCG to make sure it's going down. One of the important things to keep an eye open for if the HCG goes up, but the uterus appears to be empty by ultrasound examination, done vaginally, after the bleeding. The other concern is that it may be in the tube, that you may have a tubal or ectopic pregnancies where the embryo grows in the fallopian tube. It can distend and rupture the tube, which can be a life-endangering condition, a major hemorrhagic crisis. So it's really important to rule that out. You can do an ultrasound, but you can't always see it as clearly as you'd like. But you've got to basically check and make sure that the uterus is empty. If it's not and the HCG is going up, then an ectopic pregnancy is possible.
They just said as well, an ultrasound was empty.
If ultrasound reveals the uterus to be empty, as you've just told us, and the beta HCG level is still going up, a tubal or ectopic pregnancy is very, very possible. It's important, therefore, to go back to your doctor to get a careful, repeat ultrasound exam done of the tube to make sure it's not got a pregnancy in it. Treatment, if you get it early enough, can be effective using a drug called methotrexate. If you get methotrexate injections at the right dosage, it'll cause the ectopic pregnancy to absorb without there being serious consequences. But if it starts to bleed, you'll get symptoms. You'll get abdominal pain. Very often the pain will go up into the right shoulder. And it's interesting. The blood tracks up along the inside of the abdominal cavity to above the liver on the right, irritating a nerve called the phrenic nerve, which feeds to the shoulder. And that's why right-sided shoulder tip pain is a quite common symptom of bleeding in the abdomen. Again, you need to be checked very, very carefully. And also if you get lightheaded or you have a fainting spell, that's also a concern. You may have had a sudden bleed. Please do not try to sit this out. If you get these symptoms of pain, especially shoulder pain, lightheadedness, fainting, or anything like that, go immediately to the nearest emergency room. Don't even bother trying to reach your doctor. Get to the emergency room, because if it is a bleed that's intra-abdominal, it can be fatal and needs to be dealt with immediately as a surgical emergency. Again, my book, the thick one, has a chapter on ectopic pregnancy and a bleeding in early pregnancy. And one of the causes of bleeding in early pregnancy is an ectopic pregnancy. I urge you to comment the word Sher on one of my most recent videos, and we will send you that book and the other thin book on the immunology of recurrent pregnancy loss and unexplained IVF failure. And that'll come to you as a free downloadable ebook. We'll get right back to you.
Sounds good. I'm going to jump over to TikTok here. Sarah has been commenting a few times here. It says, I am 8 weeks IVF, but pregnancy is only 5 weeks. There is fetus, but no heartbeat. Any hope for next week?
If the pregnancy is not growing properly based on ultrasound examination and there's no heartbeat, it's not likely, but of course it is possible that there is still a live pregnancy. But it doesn't sound very good. I think you need to be prepared for the worst and hope for the best. Important to go in and get that ultrasound done, not wait at all if you're that far along. There should be a heartbeat by now that's clearly visible, and the pregnancy size should be commensurate with the duration of pregnancy.
All right, I'm going to answer this one as well. They've also commented a few times. Don't know if they meant to say endometriosis or endometritis. Okay. Does endometritis affect egg quality? 36 eggs retrieved, 4 euploids, only 29 years old.
What you're asking is whether endometriosis affects egg quality, and the answer is, if it's advanced, it can. But there's a bigger concern I've got. I think your problem with egg quality has more to do with the fact that you were hyperstimulating. You were overproducing follicles, and your doctor became nervous that you might develop severe ovarian hyperstimulation syndrome, a severe medical emergency that occurs in women that overproduce follicles, and of course each follicle contains an egg. And if your doctor was that scared, he or she might have done one of two things. Triggered you with HCG very early on in order to get the stimulation stopped so the follicles wouldn't grow any further and your risk of OHSS wouldn't increase. He might have done that. Or he might have triggered you purely with Lupron. If he gave you Lupron for the trigger, this often doesn't adequately mature the eggs in the final phase just before the egg retrieval, and you end up getting a lot of the immature eggs. This could explain why you got so many eggs but so few of them made euploid blastocysts. You only got 4 and you're 29. And the other thing the doctor could do is he could have cancelled the cycle completely. In your case, that obviously didn't happen because you had an egg retrieval. But the fact that so many eggs were harvested and you only got 4 euploid embryos, unless there was a significant underlying problem affecting your husband's sperm, the most likely explanation is that your problem is not related to the endometriosis affecting egg quality, but to the method used for ovarian stimulation. There are other ways that you can treat this without compromising egg quality, because at 29, roughly 2 out of every 3 eggs you produce should be able to be mature at the point of harvest, and if they are mature, most of those should be able to propagate healthy euploid embryos. Your failure to do that strongly indicates to me that something was wrong with the timing or the method used for ovarian stimulation. I don't know that for sure, but it sure sounds that way. And endometriosis is very unlikely to be the reason for the problem. It could be, in certain cases, if you had cysts in your ovaries called endometriomas, which are chocolate cysts, where menstrual blood collects and undergoes degeneration and looks like melted chocolate. That's why we use the term chocolate cysts or endometriomas. When that happens and there are endometriomas in the ovary, it can adversely affect eggs in that ovary. So if you had endometriomas, it's another story, and I hope to spend a little bit of time talking about that a little later on in the session on endometriomas, because there's a new way that we can treat it that we introduced, and I want to introduce that to you for your consideration a little bit later on. You don't need surgery to remove these endometriomas. They can be done non-surgically just as effectively without damaging the ovary. So, likely explanation, method used for ovarian stimulation. Again, in this case, I think personally I can help you by helping you develop an individualized, tailor-made protocol to your needs, one that will help you get a lot of eggs, but not prejudice all those eggs and have them be immature, meaning that you didn't end up with embryos, that many embryos that were euploid at the time of age, at 29 when you should have. I think I can help you. I urge you to email my assistant, Patty Converse, at concierge, C-O-N-C-I-E-R-G-E, at sherivf.com. Ask Patty to set you up with an online consultation with me where we can discuss your case one-on-one and in detail and help you overcome this problem.
Okay, we're going to get a few done here on Instagram. I want to just read this one really quick. It's very cute. And it says, "Hi, Dr. Sher. A couple years ago, we had a consultation online. You told me not to give up on my low-level mosaic embryo. This tiny former embryo is now in my lap eating lunch today."
Oh, that's so wonderful. I'm so happy. What I told you was, let me explain for the purpose of the audience. Embryos can be aneuploid, have chromosomally abnormal cells, and they can be aneuploid for two reasons. The one reason, the commonest one, is because there was something wrong with the egg. We call that meiotic aneuploidy or egg-related aneuploidy. And when that happens, all the cells of the embryo that results will be aneuploid and abnormal. And you will not have a successful pregnancy, or you'll miscarry routinely. There's nothing you can do about it. In other cases, the embryo is normal chromosomally at the point of fertilization. But then as the cells divide through a process we call mitosis, where the cells replicate, then chromosomal abnormalities occur through mutations. And some of the cells in those embryos are normal and some are abnormal. That's the term we use, mosaicism, to describe that phenomenon. We're like a mosaic. Some have a certain hue and others are different. So if you have a mosaic embryo, it means some of the cells were normal, others were abnormal. Many mosaic embryos, once they reach the uterus, will evolve and develop into a healthy baby. And that means that the normal ones have overcome the abnormal ones and have predominated. This mosaic form of aneuploidy can be picked up in the laboratory, not very reliably, but reasonably reliably. And you don't throw those embryos away, as you've just demonstrated. They can have lunch with you some years later. So it's really important that you hold on to those embryos. They're not as efficient in propagating pregnancies as those that are not mosaic and are euploid with a perfectly normal chromosomal makeup, but they are still potentially viable. Congratulations and God bless.
Okay, I'm going to answer this one. They've commented a few times. I think this is their summary here. I have had 4 euploid failed transfers, fibroids removed, clear SIS, sorry. All immune testing looks great on labs, and still no luck. I'm wondering if it's a protocol or something unexplained.
Okay. Again, embryos that are euploid have got exactly 46 chromosomes. 50 to 60% of those should propagate viable pregnancies, ordinarily. As you get older, there's a much greater likelihood that any embryo will be aneuploid. And that's why as you get older, the chance of getting pregnant on your own isn't as easy. But if you do IVF and you choose embryos and find them to be chromosomally normal, PGTA normal, or euploid, then age is largely erased as a major problem. But since I just told you 50-60% of embryos that are euploid should propagate viable pregnancies, if you've had repeated transfers with euploid embryos and not been able to get pregnant, obviously it's not the embryo, it's not the seed, it's got to be the soil or the uterus in most cases. Of course it can be because your doctor didn't do a very efficient and very gentle and effective embryo transfer. But the usual cause is that the uterus is not receptive. We call that implantation dysfunction. So in your case, a very likely cause of your failure to conceive is that the embryo has not been able to attach. And I mentioned earlier, there are many causes of implantation failure or dysfunction, but 3 of them stand out in more than 80% of cases as being the major cause of embryos that are normal failing to attach. One of those causes is irregularities in the cavity of the uterus, scarring, irregularities, or a thin uterine lining. This is more likely to have occurred in someone who's had fibroids removed, especially if those fibroids protruded into the cavity and the doctor had to go in and remove them and maybe didn't get them out completely, or some recurred. So if there are fibroids in the uterus and surgery was done inside the uterine cavity to remove them, that could have caused irregularities in the uterine cavity. So that could be a reason for failed implantation in your case. Otherwise, it's possible that all the surgery done to the uterus could have compromised the development of the uterine lining, so it wasn't thick enough, able to host a pregnancy, just not enough soil in the plant box, and you can't grow a seed on bedrock. So if the lining was less than 8 millimeters in thickness on the day that you started progesterone for the frozen transfers, or on the day of ovulation, or on the day of the HCG trigger, it tells me that the lining is too thin, and that could be an explanation for failure to implant at all, or also in many cases of miscarriages. And then the third one is immunologic. I heard you tell me that you were tested immunologically. Please believe me, these tests have to be done in very specialized laboratories. There are only 3 or 4 in America that can do the tests adequately, and to my knowledge, none that I would rely on even in the entire Europe. There are none in Canada that I'm aware of. So the tests that are done are often superficial tests that doctors use to test for immunologic causes of autoimmunity. It's not good enough, and you've got to test for the autoimmune and the alloimmune components. So my guess is that you may very well have an underlying immunologic implantation dysfunction, which could be autoimmune or alloimmune, and I described that earlier. But for those of you that are interested, I am going to be sending you, if you comment the word Sher on one of my most recent videos, S-H-E-R, I will then send you copies of 2 of my books written by me and my partner, the medical director in New York, Dr. Drew Tortoriello, and we've been working together for decades. And Dr. Tortoriello and I, along with Dr. Ravi Kumar, work out of New York. So you get a copy of my books. One of those books is the book on IVF itself, over 300 pages long. It's not out yet, but it's available to you as a free downloadable ebook. All you got to do is comment the word Sher. The second book is a book on the causes of unexplained IVF failure that are linked to immunology, and the causes of repeated miscarriages that are linked to immunology. That book's only 50 pages long. You're not going to get that information readily anywhere else. So I urge you to comment the word Sher, get those 2 books and read the thin book, so you've got more information available to you about the failure of implantation that can be immunologic, and will explain the difference between the autoimmune and the alloimmune causes of implantation failure. Again, comment the word Sher and these books will come to you, and if you really want to discuss this with me, and it sounds like I might be able to help you, again, simply email my assistant, Patty, at concierge, C-O-N-C-I-E-R-G-E, at sherivf.com, and she can set you up to have an online consultation with me.
Okay. Thank you all for commenting. We're gonna try to answer as many as we can. If we do not get to your question today, please go leave a comment on one of our most recent videos, or leave the word Dr. Sher, spelled S-H-E-R, on the most recent video, and we'll reach out to you, send you ebooks and information. I'm gonna go over here.
You know what I'm going to do now? I'm going to talk a little bit about that topic I wanted to raise, I mentioned earlier on. I
Okay.
think most of the people that are with us are with us now. So let me at least get into this.
Okay.
Is this okay?
Yeah, that's fine.
Good time. I want to talk to you about endometriosis for a moment. I want to tell you that many people who have endometriosis are also unable to conceive. In many cases, about a third of such cases, the cause of the failure to conceive is an immunologic cause, which we deal with through treating, if it's present, the immunologic problem, which presents like an autoimmune cause where natural killer cells, these large lymphocytes that are in the wall of the uterus that regulate the implantation process, are not releasing cytokines properly. And we can identify it if you have your blood tested in one of 3 labs. Other cases of infertility due to endometriosis occur because all women with endometriosis have deposits of endometriosis in the pelvic cavity. By definition, these deposits are deposits of endometrial tissue outside of the cavity in the surrounding tissue. These deposits release toxins into the secretions of the pelvis. So as the egg comes through the tube after ovulation, leaving the ovary normal, gets into the tube and goes down the tube, it's got to cross over that space between the ovary and the tube, where it comes in contact with these toxins. And if it does, the egg is rendered far less fertilizable by a factor of 5 or 6. So if the normal chance of a woman in her early 30s getting pregnant per month on their own, if they're perfectly fertile, is 20%, roughly, it'll be probably about 3% in a woman who's got endometriosis, even if the tubes are perfectly normal and patent, even if you've done surgery to try to get rid of any deposits in the pelvis. I make this point because you cannot get rid of all the endometriotic deposits. They are with you for life. And you can only get rid of those you see. And for everyone you see, the whole bundle coming up again. It's a work in progress. It never stops giving. And these toxic effects reduce the chances of getting pregnant dramatically, even if the endometriosis is the earliest possible stage, stage 1. And even if you've gone in to remove it, remember, you cannot remove all the endometriosis. You can only remove what you see. So that whether you do surgery in such cases, or whether you give a woman fertility drugs and do intrauterine insemination, or whether you do nothing, the chance of getting pregnant is no better than doing nothing at all. Only IVF, which removes the eggs from the ovaries before they're released into this environment, fertilizes the eggs outside the body, puts the fertilized embryo in the uterus, if that's a good embryo, and there's no implantation problem, which is linked to endometriosis, it'll make a baby. So IVF improves chances. I'm not suggesting that all women with endometriosis need IVF. They don't. If they have these early stage endometriosis, then you can keep on trying. But you can't keep on going for too long, because there'll come a time when the biological clock starts to play a role. Your age and the reduction in ovarian reserve that goes along with aging and goes along with damage to the ovary will compromise matters further. So for women under 35 who feel they've got the time, who've got perfectly normal tubes and want to wait and are willing to settle for a 5 or 6 times lower chance of pregnancy, you could try on your own. Don't think that doing intrauterine insemination, which is a procedure I introduced into the field of IVF in 1984, is going to help you. It won't improve your chances. Using fertility drugs will usually not improve your chances either. And so if you do these things, or even surgery to get the lesions, if you do get pregnant, it's not due to the treatment, it's in spite of it. Many doctors will put you onto Lupron, Depo-Lupron, for several months to get you ready. In my opinion, that doesn't help either. In fact, it causes more problems, because Lupron sends a woman into a pseudo-menopause state. The estrogen dries up, and you need estrogen to be able to prepare your uterus with a proper lining. I don't use Lupron in patients with endometriosis, except if it's to prepare the woman for surgery, because the effects are temporary and they only get you ready for surgery, reducing the size of the lesions to make it easier to do surgery. Frankly, I don't think surgery is ever a good idea for endometriosis unless it's to treat symptoms or get rid of advanced disease. But I want to focus on one particular element that's really important. So for those of you that have endometriosis, and those of you that are friends with endometriosis, or get into meetings where people are talking about endometriosis, please listen up to what I have to say now. As I've mentioned earlier on, in stage 2 or 3 endometriosis, women often develop endometriosis-related cysts in the ovaries because they bleed, and they bleed from tissue that is from the lining of the uterus. So it's like menstrual blood, and that blood builds up in the cyst within the ovary and becomes decomposed, and it ends up looking like melted chocolate, hence the name chocolate cysts or endometriotic cysts. Now here's the important point I wanted you to take home. When you have endometriomas or endometriotic cysts, you'll hear from 99% of your doctors that the treatment of choice is to do surgery and either remove the cyst or ablate the inner lining of the cyst by lasering it away. I want you to know that this is no longer necessary. You don't need to do surgery for endometriomas. So why would you want to do a surgery, or why would you want to remove it? Because if the cyst is larger than 2 centimeters in size in either of the ovaries, that ovary so affected will produce eggs that are of a much poorer quality and be far more likely to be immature when you get them and not be able to make euploid embryos. We did a study which we've not yet published. The study looked at women who had endometriomas involving only one ovary. We went in and we did IVF because they didn't want to have the endometrioma removed. They'd been convinced by a previous doctor that it's not necessary, and it is necessary, because if you leave it behind, it'll irritate the ovary and cause the eggs in that ovary to be compromised. So you've got to remove it if it's more than 2 centimeters. But we went in and we took eggs from both ovaries but separated them and then fertilized them, and then we looked afterwards to see what the quality of the eggs were from the ovary that wasn't affected versus the one that was affected. And we also looked at the embryos that came from the ovary, from the fertilization of the eggs from the affected ovary versus the unaffected ovary. And what we found was the one that the eggs that came from the ovary that was affected were far less likely to be good quality. And again, I told you earlier, it's the egg and not the sperm that determines the competency or the chromosomal normality of the embryo, an essential prerequisite for a viable embryo to be propagated. We learned this, and then we went in and we removed the endometriomas. We used a new procedure that is non-surgical. You don't need anesthesia, you don't need laparoscopy, you don't need laparotomy. What you need is something called sclerotherapy. S-C-L-E-R-O-T-H-E-R-A-P-Y. Sclerotherapy. About 15 years ago, I was the first to describe that if you go in, actually it may be longer even ago, that if you go in and put a needle into the endometrioma, suck out the chocolate fluid, the menstrual blood from the cyst, and then inject a substance called tetracycline hydrochloride. The cyst would collapse, it would sclerose and fibrose the inner lining, it would collapse, and 6 to 8 weeks later, 90% of the women would have no cysts, and those that did, all you had to do is go in and drain it, it would collapse and wouldn't come back again. So sclerotherapy was an excellent treatment with one big caveat and one big problem. Very often the tetracycline would leak out of the cyst into the cavity of the pelvis, into the abdominal cavity, irritate the membrane that envelops all of the pelvic cavity, irritate to the point that the woman had severe pain. It was really a major concern. It occurred in about 1 out of every 8 to 10 people we did sclerotherapy on, discouraging us from using it because patients were complaining, and it wasn't giving us good press. It worked, and it wasn't dangerous. Sure, the woman would have pain, and we'd have to observe them and watch them for several hours post-operatively, but it was still successful. And that's the way it remained until some time, quite recently, when it became determined that we didn't need to use tetracycline hydrochloride. We could in fact use 95% alcohol solution and drain the cyst and inject the alcohol with no significant side effects. It didn't irritate the lining, and it did basically do exactly the same thing, caused the cyst to collapse and fibrose up and absorb. And the advantage of sclerotherapy is A, it is just, or if not more successful than doing surgery to remove the endometrioma. Secondly, it is now virtually risk-free if done correctly and done in the right cases. And thirdly, it is much less expensive and painful than surgery and costs a lot less. A cyst aspiration, which we can do very often, I think, and we haven't had any problems, by aspirating the cyst. It's often covered by insurance, but not necessarily always. We can do it as an outpatient procedure with a woman under conscious sedation. She gets up from the procedure, goes home, walks out the door, and the problem is gone 6 to 8 weeks later. Why would you go in and do a surgical procedure which is traumatic, painful, costly, and oftentimes also causes the removal of a certain amount of ovarian tissue to get the entire cyst out, which in the process can destroy eggs, when you can do a completely benign, safe procedure called sclerotherapy. I urge those of you that are interested, and again, please help me here, spread the word. We can help people with endometriomas. And that's really the only major reason for infertility surgery in IVF. It can be eliminated by using sclerotherapy. All they've got to do is email my assistant Patty Converse at concierge, CONCIERGE at sherivf.com. Set up a time to discuss this with me online, and I will also send you information that I've written on sclerotherapy, and then you can get into the program. It's getting very busy, so please don't renege to do this. It can be very helpful. Again, please spread the word around. Sclerotherapy is a non-surgical, non-invasive surgical alternative to what is currently used almost across the board to treat endometriomas. Thank you for listening to that. I hope it's helpful to some of you.
All right, do you want to reiterate what our topic is today, the 3 topics?
The 3 topics we're talking about today, again, are endometriosis-related infertility. I wanted to focus on the sclerotherapy aspect and on the immunologic treatment of implantation dysfunction linked to endometriosis in a third of cases. The second one is immunologic causes of repeated failed IVF transfers. And again, this is much too often overlooked. If you overlook it and you keep on doing the same thing over and over again, and someone's ignored the immunologic problem, it will keep recurring. And it's extremely important to get it tested in one of the 3 or 4 labs in America that can do these tests, and we can help you do that. And the third one I wanted to talk about was what was the other one? Recurrent pregnancy loss. Again, often due to an immunologic cause.
All right. With that in mind, please comment any questions that you have. Questions are now back open, so Dr. Sher will be answering.
And by the way, we'll go on a little bit over time today,
Yeah.
because I took so long talking about the endometriomas.
Yeah, and if you want to talk in, once we answer a few more questions, go into the other 2 topics and just talk a little bit about those as well.
Well, those, all right, I'll do that.
All right, I have another one here. I've been waiting for a minute. It says, I have HEDS and MCAS and ADHD and autism. Does that correlate with allergic reaction to progesterone and causes miscarriages? Anything I can do?
I didn't quite get that question. I have what?
They have a couple of different things. They have HEDS and MCAS. I'm not sure. They're all capitals.
Could you please repost your question? We'll get to it immediately. Spell those out fully. Give me the full names and I'll address it.
Yeah, we'll wait for her to respond on that one. We're going to go over here real quick. Let me see. I have one here they've asked a few times. Using Lovenox without blood disorder, history of recurrent losses using PGT and MODIF, MODIF, natural protocol. I'm not sure.
Okay, first and foremost, it's like, when you tell me you used Lovenox, which is a heparin-like substance, and I was one of the first people ever to describe the use of heparin for implantation problems. It has a role, but you can't use it alone unless you've ruled out all the other causes. Heparin is used in cases where there is a condition called thrombophilia. That means a woman's got a hereditary clotting defect of certain varieties. And one of them is a homozygous or double mutation involving MTHFR. So it can be used and should be used in those cases. But heparin alone otherwise doesn't have much of a place. It can also be used where there are antiphospholipid antibodies, APAs as they call them. One of those you often hear the doctor talking to you about is called lupus anticoagulant or cardiolipin. Please believe me, whenever I see someone tell me about the fact that they tested for lupus anticoagulant and cardiolipin, I get worried because there are 21 different types of phospholipid antibodies across the spectrum of IgA, IgM, and IgG, and you've got to know exactly which ones are involved. As a matter of interest, cardiolipin is the least important. It is a deep-seated cardiolipin antibody. It's a deep-seated phospholipid antibody, so it isn't one that usually causes a problem, and it's only present 6% of the time. And the other one, no question of a doubt, if you've got these antiphospholipid antibodies, you need to look deeper to see which ones are present, because some of those need to be specifically targeted. But just going on Lovenox alone frightens me, because it means nobody's looked close enough, and if you don't cover all of the aspects of the immunologic issue, you will not be successful in treating it. And it requires testing being done in one of 3 laboratories in the United States that we use. The one I like using is in Boston, Massachusetts. It's called ReproSource. If you want to know more about this, I urge you to comment the word Sher. We will send you both the books, the thick one and the thin one on immunology. So please comment the word Sher. We'll send you by return ebooks that you can download immediately and read.
Make sure you comment that word Sher on one of our most recent TikToks, videos, or our reels if you're on Instagram. There's more information on that other question we just answered.
Please, go ahead.
She also said, I have no blood disorders or autoimmune issues, just 4 losses. I do have one MTHFR mutation.
Oh, that's what you were saying.
No.
Well, MTHFR, one mutation, will not explain you failing to get pregnant.
Okay.
What it sounds like to me is that you've not been fully evaluated. You may think you have, but you've probably had your blood tested in a local reference laboratory, like LabCorp. It's not good enough to do all the testing. They're not sufficiently sensitive or specific. You need to be tested properly. And if you've got recurrent failures or recurrent losses, I urge you to get tested properly. Again, comment the word Sher. We will send you information on those topics. You'll be able to get them in the form of downloadable ebooks. And if you want to talk to me, just reach out to Patty through the email address that I've given several times.
I'm going to go back over this other question we had earlier. She elaborated what those mean. So,
Okay, sorry.
We have, I might butcher this word, but it says Ehlers-Danlos.
Oh, Ehlers-Danlos syndrome.
Uh-huh.
Okay.
And then mast cell activation.
Mast cell activation. What was the question relevant
So
to those?
with those 2 plus ADHD and autism, does that correlate with allergic reactions to progesterone and causes miscarriages? And if so, is there anything she can do?
No, there's no correlation to the best of my knowledge with any of those conditions. But of course, Ehlers-Danlos is something that you've got to be on the lookout for and maybe be tested for if you have embryos and have them evaluated before you put back. You want to try to avoid transmitting that if you can.
I'm going to go back up here. There's been a few.
And the mast cell situation is a situation that does cause major acute and crisis-like allergic responses. Mast cell syndrome is a cause of things like anaphylaxis, is a cause of hives, is a cause of major allergic responses, but that's a different type of immunologic issue than what we're referring to here when it comes to implantation dysfunction.
Okay, I'm going to answer this woman's here. She's asked a few times. Is mild diffuse endomyosis with 14 millimeter or 14 mm junctional zone going to cause recurrent miscarriages?
Adenomyosis, the condition you're referring to here, was previously referred to as internal endometriosis, whereas the endometriosis we've been talking about was commonly referred to as external, suggesting they're the similar type of conditions. They are not. They're completely separate conditions. Endometriosis is more common in women with infertility. Adenomyosis is more commonly seen in women who've had many babies. My own wife had adenomyosis and we have 4 children. Adenomyosis only, in my experience, causes a problem with ability to conceive if there is damage done to the uterine wall sufficient to compromise the blood flow to the uterine lining such that the lining can't get thick enough. Because with adenomyosis, the uterine lining grows inward into the wall of the uterus and it winds its way in between the muscle fibers and blood vessels, interfering with blood flow and delivery of estrogen to the lining. Of course, estrogen is necessary to build an adequate lining, which you've got to have. It's got to be better than 8 millimeters at the time of ovulation or progesterone administered. So adenomyosis, if there is no thinning of the lining, isn't the problem. If there's a thin lining, then you have to address it. And the way to address it is to treat the woman with, and surgical treatment doesn't come into it. You treat the woman with a medication that dilates the blood vessels, takes the pressure off them, to improve blood flow of estrogen to the lining. I published on this some time back. And we use a drug called sildenafil, commonly known as Viagra. Men use it for erectile dysfunction. The way it works in men is it engorges the organ with blood, so of course it enlarges. If you put Viagra suppositories, specially compounded by an organic compound pharmacist, into the vagina 4 times a day during the cycle that you're preparing the woman for transfer, it'll be absorbed directly into the uterine wall, open up the blood vessels in the uterus, and you'll get a better flow of estrogen, which you of course are administering or producing, which makes the lining thicken. And now you've got a better flow of estrogen to the lining and can often reverse it. If it fails to reverse it, you have a serious issue on your hands. You may never be able to be successful carrying a baby if the lining's too thin. One thing I would not recommend is putting an embryo into a uterus that is too thin, 7 millimeters or lower, because if you do that and the embryo does attach, it's usually going to miscarry. Or if it grows, there'll be inadequate development of the placenta, and you may get a baby being developed with intrauterine growth retardation, placental insufficiency, which can compromise life after birth. And what we do in IVF is not about getting a woman pregnant. It's about getting a woman to have a baby that will have optimal potential in its future life. That's far more important. So I urge you to consider if your lining is thick enough. This is not the cause of your problem. If your lining is too thin, you may need treatment with vaginal Viagra and estrogen. I urge you to, again, get a copy of my books where I discuss this in one of the chapters. All you've got to do is comment the word Sher on my most recent, one of my most recent videos on, I think, Instagram or TikTok or Facebook, right?
Yeah. Yep.
Apparently it can't be done through the YouTube venue. Is that
There is no way to reach out to people through YouTube. So if you're on YouTube, please go to the Instagram or TikTok and comment the word Sher on any of our videos.
Or alternatively, pick up go to your computer and email Patty at concierge@sherivf.com. Tell her you want a copy of the book, and she will send it on to you from that email.
Awesome. All right, bear with me. We have a lot of questions coming through on both platforms here for Instagram and TikTok.
Quite busy today.
It is quite busy, yes. Looking for something with it. Okay, here's one. This is an endometriosis question. She says, can you get pregnant with stage 4 endometriosis? And if so, what can she do?
Again, yes, you can. Stage 4 endometriosis means endometriosis that is advanced. And usually in stage 4 there are endometriomas. For those of you that never heard me talk about it earlier on, I urge you to go back and listen to this feed again so that you can pick up on that. Yeah, they've often got endometriomas, they've often got lots of scarring in the pelvis, and they've often got lots of deposits of endometriosis all over. Yes, you can get pregnant. You've just got to be more diligent. Focus on the ways in which endometriosis causes failure to conceive with IVF or infertility. One of those ways, as I've told you, is the toxic implants themselves that you bypass by doing IVF. The second way is by going in and dealing with any endometriomas that are present, and that, as I've said to you, the new approach that we are promoting is called sclerotherapy, and we will be happy to discuss that with you if you reach out to us. The third way is the immunologic impact that occurs in a third of women with endometriosis, which is not more likely to occur in more severe forms of endometriosis than it is in milder forms. It's regardless of severity. So if you've got an immunologic problem, that needs to be identified, quantified, and typified, and that we need to discuss. And then the final one is if there's been severe damage to the ovary itself. It may have reduced ovarian reserve and destroyed many of the eggs in the ovary. It can even push a woman into earlier menopause. So if you've got diminished ovarian reserve with endometriosis that's advanced, then the protocol used for ovarian stimulation, once you've dealt and addressed all those other issues I've just mentioned, must be addressed. And that is, after you've dealt with all those things, then you've got to use an individualized approach for ovarian stimulation. All you've got to do to get more information on that is you've got to comment the word share. We'll send you the copies of the 2 books which discuss this in some detail. And for those of you that want to know more and would like to talk to me, I urge you to email my assistant Patty at concierge@sherivf.com, and she can set you up with a consultation to discuss it with me. For those of you that have endometriomas that need to be addressed, I urge you to be in touch with us because we can help you avoid unnecessary surgery.
Awesome. I'm going to answer V here. I see you've been asking a couple questions here, a couple times here. I might butcher this word. I apologize in advance. Do asymptomatic? I'm going to butcher this next word as well. Isthmoceles? Yeah, here. I'm going to have you. Sorry about that.
Yeah, it's all right.
I'm learning just as well.
Isthmoseals.
This question.
Oh, I know what you're saying, yeah.
Sorry about that.
The word isthmocele isn't commonly used. It means there's a collection of cystic-like fluid where the tubes leave the uterus. If those have been surgically corrected, then the question arises, was any damage done to the inner lining of the uterus causing irregularities that could interfere with implantation? I really would need to see the report of a hysteroscopy or repeat the hysteroscopy where we put a telescope-like instrument through the cervix into the uterine cavity and evaluate the integrity of the cavity. I would need to look at that or review pictures or reports of a saline ultrasound done and review all your records carefully to give you advice on that. I can't just do it off the cuff here. It depends upon how large they were, how many they were, and how much surgical repair caused distortion of the uterine cavity. Again, if you want to talk to me about this, contact Patty through my email, the email address I gave you, or get a copy of my book by commenting the word share on the most recent video that I did.
Awesome. Alright, let me keep going. Let me go over actually. I'll answer this one. I have 2 endometriosis over 5 centimeters, but was able to get 4 euploid embryos. Any risks to transfer now?
No, once you've got euploid embryos, the obstacles are gone. Once they've dealt with the endometriomas and you ended up getting a number of euploid embryos, provided those embryos are placed in the uterus gently, and again, here's the word of caution, provided you've excluded and eliminated a possible immunologic implantation dysfunction which occurs in a third of women with endometriosis who've got activated natural killer cells, provided you address those at the same time as the transfer and do it appropriately, you should be able to get pregnant as easily as if the endometriomas weren't there.
Alright, we're going to jump back over to Instagram real quick. They've been waiting for a minute. This is 2 questions they asked, but we'll just go through each one. It says, any success tips for PCOS? And then the other question is... any success tips for PCOS? And then she got a second question that says, can high fasting insulin impact success rate of an IUI or IVF?
Okay. PCOS, or polycystic ovarian syndrome, is a condition which occurs in the ovary where there are multiple large numbers of small follicles, little subcapsular cysts. We often hear the description by ultrasound of a neck of pearls appearance, a string of pearls, where these little cysts are right under the capsule of the ovary. The woman is usually at risk of producing far too many follicles and developing a condition called severe ovarian hyperstimulation syndrome. Now, I'm not going to go into here on the actual cause or the details related to the cause of PCOS, but there are cases where the woman often tends to be a little shorter, tends to be have increased hair growth, and the periods are irregular. She's infertile. She's not having periods at all, or periods are far apart or irregular, and she's often got very high levels of AMH, anti-Müllerian hormone. Anti-Müllerian hormone being high indicates that there are large numbers of follicles ready to take off. And now you should view this as being like someone who's, if you've got a patch of gasoline on the floor in front of you, and you drop a match, a flame on that gasoline, it'll just turn into a blaze immediately. That's what happens in women who've got all these follicles, even very often with low dosage of fertility drugs, which is like the match, like the flame you're applying to all those follicles, to that patch of gasoline. So they all suddenly take off and grow, and if too many of them develop, then the woman is at risk of OHSS, which is a life-endangering condition and is very much more common in women with PCOS. Which brings me to the fact that treating PCOS requires a lot of understanding on how to try to avoid this overdevelopment of all these follicles and avoid overstimulation. What a lot of doctors often do when too many follicles develop, they see the estrogen levels going too high, they see the follicles developing en masse in large numbers, so they'll stop the cycle and trigger early on, earlier than when the eggs are ready to come out. And so that by triggering with HCG before the time is ready, the follicles aren't ready to yield good quality eggs, and you'll end up with poor quality eggs and therefore poor quality embryos and failed IVF. So in this kind of situation, the protocol has to be tailored to try to prevent that from happening without enabling the eggs, or not allowing the eggs to come out before they're ready. And one of the things that the doctors often do is they trigger with a drug called Lupron. Lupron works well to reduce the risk of OHSS, but it often comes at the expense of egg quality, especially when you give Lupron alone and not in combination with small amounts of HCG. And if you use Lupron to trigger, there's not enough of an effect to mature the eggs in an orderly way, or the follicles in an orderly way, and you end up with a lot of poor quality eggs. There's a method that you can use called prolonged coasting, which I write about in my book because I introduced it 20 years ago. Prolonged coasting can allow you to allow the follicles to grow in an orderly fashion and prevent hyperstimulation without necessarily compromising egg quality. But it's got to be done expertly by someone who really knows the nuances on how to implement it. So prolonged coasting is another method that can offset the effects of OHSS and without compromising egg and embryo quality. So PCOS is a condition that you must be on the lookout for. And if you ever see a woman with irregular periods, and even if she's got regular periods but got a high AMH, and if you do a blood FSH and LH and find that the LH level is much higher than the FSH level, it's usually the other way around normally. You've got to suspect underlying PCOS-like condition.
Okay, let me go back up here. Let's see. I'm going to answer this person on Instagram real quick that just commented. It says, first IVF cycle, miscarried at 6 weeks. When to start the next cycle again?
You must first make sure that your uterus is empty and get an ultrasound to make sure there are no retained products of conception from the first miscarriage. And if the uterus is empty, allow yourself one full cycle to recover, have a period, and then get into a cycle.
I'm going to go back over to TikTok real quick. If you guys have commented a bunch of times and I haven't seen it and you don't get your answer or question answered today, please go comment on one of the most recent videos and we will get back to you or reach out with a ebook consultation or more information. All right.
Or we'll directly call you. If we can't get you, we'll pick up the phone and contact you directly with a direct communication.
Absolutely. So be sure to go comment the word Sher, S-H-E-R, on one of our most recent TikToks or Reels. Let's see. We have a bunch of questions coming in. Sorry, let me find one.
I think we'll go about another 10 minutes and then we'll have to.
Sounds good. Sounds good. I answered this one. When to start down reg suppression for EC with long irregular cycles, won't have ovulated by CD21. I don't know if that makes sense.
I think you're saying that you have irregular cycles and you don't know exactly when to start the down regulation protocol. In such cases, I use the down regulation protocol that starts on a birth control pill. So I put the woman, the period starts onto a monophasic or combined birth control pill like Desigen or Orthonovin 135 and put her on it for 10 days. After 10 days, I'll overlap the birth control pill with Lupron for 3 days. Often I'll add human growth hormone to the mix because that augments mitochondrial activity in the egg and improves the egg development. So for 3 days you're on the birth control pill and on the Lupron and on the human growth hormone. And then after 3 days, stop the pill. But continue the daily shots of Lupron. Within a week, you'll have a period. And as soon as your period starts, we get a blood test to make sure your estradiol level is low enough. It's got to be less than 70 picograms per milliliter in American units, or less than 200 picomoles in Canadian, European, or Australian English units, and picomoles per liter. And then if it's below that threshold and an ultrasound shows no cysts, at that particular point we'll start stimulation with predominantly FSH recombinant products like Purigon, Follistim, or Gonlef daily, adding to that 75 units of Menopur, or the equivalent of Menopur, for 3 days, and after 3 days we drop the dose of the Follistim, Gonlef, or Purigon, keep the 75 units of Menopur, and then stimulate, and we begin doing ultrasound examinations 6 or 7 days after you start on the Follistim, Gonlef, or Purigon. And then we do daily ultrasounds. As soon as we see enough follicles that are over 15 millimeters, at least 50% have to be over 15 millimeters, and several of them between 18 and 22 millimeters. When we see that, and it correlates with your blood estrogen level, that's when we will trigger you with HCG. A little bit back, when you start taking the shots with Purigon, Follistim, or when you take the FSH recombinant and the Menopur, we basically will also have switched you over from the Lupron, in many cases, to a GnRH antagonist known as ganirelix or cetrotide or orgalutron. Lupron is an agonist, those are known as antagonists, so that protocol is called an agonist-antagonist conversion protocol, and I confine patients who have got some diminished ovarian reserve, not severe but mildly diminished. I give them those protocols. Whereas a woman that's got a high AMH and has got lots of ovarian reserve, I'll just continue the Lupron without switching over to the antagonist all the way through to the trigger day of HCG. And when you get the HCG trigger, you get 10,000 units of Pregnal, Profaci, or Novarel, or 500 micrograms, that's 2 vials of Ovidrel. And 36 hours later, we go and remove the eggs. If you want to know more about that, about those protocols, or you'd like to talk to me about them, reach out by commenting the word Sher at the most recent video that I did on Instagram or TikTok or Facebook, and we will send you copies of those books for you to read, or contact Patty Converse at concierge@sherivf.com, and she can set you up with an online consultation with me to discuss your case in detail.
You want to answer one more question?
I'll take one more question.
Okay.
And then I'll make a few comments about some of those other things.
All right, we'll answer this one here. What is the best protocol for immature eggs after retrieval for someone with DOR?
Oh my gosh, I've just described for you the agonist-antagonist conversion protocol, where you're on a birth control pill, you overlap with Lupron, and you take human growth hormone, you have a period, then you switch from the Lupron to the ganirelix cetratide, which is an antagonist, and go forward as I described. That's called the agonist-antagonist conversion protocol. If you've got DOR, that diminished ovarian reserve, that is very severe, we'll often add one extra component, and that's prime with estrogen from when your period starts for a couple of days, to make the ovaries more responsive to the stimulation that's coming.
Okay. If you want to thank everybody real quick.
Okay,
yeah.
A couple of points here. First and foremost, the most important of all, this is an extremely important part of the year. This is a time when we look back on everything we did in the year before, and we grade our performance as human beings, not as professionals or whatever else goes on in our lives. This is the time we need to think of family, we need to think of friends, we need to think of those that are helping us stay safe in this country, and we need to start thinking about what we can do to help others. I hope that today's session was helpful to you, gave you information, and more important, inspiration. I can't think of many cases where we can't do anything to help a woman have a baby, provided the right things are done, provided it's done with the right intent and executed correctly by people that care. I often say you can teach a doctor to give care. You can't teach any doctor or person to care. And I don't want to work with people that don't care, because that's what it's all about. So it's important at this time that you realize that caring is a very important part. You deserve it, and others deserve it from you. So I'd like to take this opportunity of wishing everyone here a very joyous and Merry Christmas, and a wonderful, healthy, productive, and fulfilling 2026. If there's anything I can ever do to help you, there are no conditions. All you have to do is reach out, and I'll be more than happy to help you as best I can, because that's what life's all about. Thank you for attending, and I hope it's been helpful to you.
Thank you all. If you did not have your question answered today, please go comment it on one of our most recent videos, or just comment the word sure, and we will get back to you.